Okay, we're continuing with the book. This is part 3 from Prevent and Reverse Back Pain by me, Pete Rogers. We're on page, I think, 15. Here is a drawing of the disc, the spinal disc between the vertebra bones. The outer part is called the annulus fibrosus, and it's like a steel-belted radial tire. It's very strong. In the center is what is called the nucleus pulposus, and that's like a jelly donut. It's soft like a gel, and it's like a waterbed, okay? And the disc helps to equilibrate the weight across the vertebral bodies, to distribute it more evenly, to support some of the weight. Okay, those are really important metaphors to get. Steel-belted radial tire is annulus fibrosus. Nucleus pulposus is like the filling of a jelly donut. Okay, there is innervation, meaning a nerve supplies the annulus fibrosus. So injury to that disc can cause pain through the sinovertebral nerve. And remember, nerves often can manifest with pain if they don't have good blood flow, ischemic pain. They can also be compressed by a disc, by a bone spur, and that can cause pain. But when you improve blood flow to nerves, often their pain diminishes. Okay. Okay, let's see here. The disc is also like a cushion or a shock absorber. Okay. So now we're going to talk about what happens when the disc degenerates. When you don't have enough oxygen going to it, enough glucose going to it, or there's problems with the collagen too for all the chemicals I talked about earlier that can inhibit it, you can get tears in the disc. A little tear is called an annular fissure. And I'm going to show you what the shape of a disc herniation and looks like. A disc herniation can be called a protrusion or an extrusion. Protrusion means little disc herniation. Extrusion means big herniation, and I'll show you some pictures there in just a moment. Okay, here's another illustration of a disc. So this is the lumbar spine again. S1 is sacral vertebra number 1, L5, lumbar vertebra number 5, L4, lumbar vertebra number 4, L3, lumbar vertebra number 3. Okay, the nucleus pulposus in the center. When you get a tear in the annulus fibrosus right here, and an annular fissure it's called, then the disc can herniate out. This would be a disc herniation. Well, right here it's just an annular fissure, but if it starts to bulge beyond the posterior end plate margins, then it would be a disc protrusion. And if it goes above or below, then it's called an extrusion. On a T2 MRI, that's the MRI where the fluid signal is bright, you'll see what's called an HIZ, a high intensity zone in this spot. That's how we usually diagnose it on a sagittal MRI, is we would say, L4-5 disc with posterior high intensity zone consistent with an annular fissure. And the reason they care is that can be the source of pain. That can be the pain generator, because that's really the question they're asking with an MRI. Can you find the pain generator, what's causing the patient's pain, and does it look like something that would benefit from surgery or injection of steroids, for example? Okay. Here's what the end plates look like. Upper end plate, lower end plate, L3 vertebra. And these upper and lower end plates have a cartilaginous bone, endochondral ossification, and they have relatively poor blood supply, even under good circumstances. This right here would be an example of a narrowed disc because it's dried out, desiccated, and you'll have a loss of disc space height. So that's consistent with degenerative disc disease. And that's what I see all day long on almost all the patients. Okay, now I'm going to show you a little bit more, getting the idea of what the disc look like a little bit on an MRI. Basically, there's two main types of MRI. There's T1 and T2. So here's T1 where the cerebrospinal fluid is dark. Here's a T2 drawing of a T2 MRI where the fluid is bright. So basically, like in zoology, there's animal kingdom, plant kingdom. In MRI, there's basically T1 and T2. And if you want to understand anything about MRI, this is the most important thing. This is the foundation of all MRI. I've been looking at MRIs for like 40 years, and I can tell you, this is the foundation of everything. On T1, fluid is dark. On T2, fluid is bright. Everything comes from that. Okay, so T1 is good for looking at especially the vertebra. There's going to be a little bit of fat in the bones, so that's normal to have a little bit of T1 hyperintense signal. Okay, the fat's going to be a little bit bright, but you can get a little bit of bright signal on T2 as well. But the difference is it's more visually apparent when you see a tumor replacing these VBs. But we're not going to be talking about spine tumors, but I'm just letting you know when I'm looking at T1s, I'm always looking, is there any evidence of METs, metastatic tumor? Okay, even though I rarely see it, when I see it, it's a big deal to diagnose it. So that's why I always look carefully at the VBs, the vertebral bodies, on T1. On T2, it's a better sequence overall. If I only had a single sequence to read the whole case, I would read it off a sagittal T2 MRI image of spine. Okay, I look first, is there foraminal stenosis? I come out to the foramina. Then I go back to the center of the disc space. Is there a disc herniation, diffuse disc bulge? Is it causing central stenosis? Yes or no? And I do that for every single level. Okay. All right, now here I'll give you a little bit of an idea. This is some pretty basic terminology for having a conversation about spine MRI. When the disc projects posteriorly, that's a disc herniation, and if it's at even with the height of the native disc space, that's called a disc protrusion. If the disc, when it herniates out, it goes upward or downward, then it's called a disc extrusion. So protrusion is like a code word that usually means small disc herniation. Extrusion is like a code word that means big disc herniation. These terms were developed to help spine physicians communicate effectively. Okay, so a protrusion usually means surgeon's not going to operate. An extrusion means it's more likely to potentially benefit for an operation to have a surgeon decompress the disc. Now there's obviously more to it than that, but that's the general gist of what they mean. And if I describe a disc extrusion, I would say L4-5 disc extrusion with upward and downward extension. Okay, that's how I would describe that on a MRI report. Okay, and then the next question is, can disc degeneration cause pain? Yeah, it can. And like I just said, the disc is innervated by the sinovertebral nerve. Okay, and it can be compressed, it can be ischemic. Do disc herniations cause pain? Yeah, they can, because they can cause a tear in the annulus fibrosus, which can affect the sinovertebral nerve, plus they can extend posterior into the central spinal canal and compress the dural sac and the CSF and the nerve roots going by. They can compress the nerve in the foramen, so they can cause pain in all those different ways. Okay. Disc desiccation by itself is usually asymptomatic. You see that in normal volunteers too with degenerative disc disease. The big thing about disc drying out is it'll lose height, and then you can get foraminal stenosis, which can lead to compression of the nerve in the foramen. Okay. Disc space narrowing can be mild, moderate, or severe. When it's severe, you're going to lose more foraminal height. Okay, I'm going to show you, here's another picture. This one's in color. So this would be what? Disc protrusion, because it stays at the height of the VB. Okay, this is an extrusion with upward and downward extension. This is a disc herniation into the end plate itself. That's called a Schmorl's node. In this particular drawing, I'm using the yellow color here to represent fat. So this is the epidural space. The dural sac's in the middle, so the space around it. Epi means above or around. So this would be the epidural space, and this is fat in the epidural canal. So this is epidural lipomatosis, meaning epidural space, fat, a lot of it. That's sometimes a cause of compression of the dural sac in the lower lumbar region especially. So that would be epidural lipomatosis. And the relevance is that when a person loses weight, they can shrink that fat a little bit and you have a little bit of less stenosis. Okay, I mostly see that in really fat people. It's not that common, but I do see it every week. Okay. Degenerative disc disease, I see almost every patient, tons of patients every week. I could see that in 100 patients in 1 week. Okay. One little debate you'll sometimes hear is, should patients be told? There's some spine pain management doctors that say you shouldn't tell a patient they have degenerative disc disease because they get scared. No, BS. Tell the patient the truth. What you really should tell them is, yes, you have this, and you can potentially significantly decrease your symptoms if you're willing to eat a low-fat vegan diet, no oil, no processed food, organic only, get your sleep, do some exercise, walk and manage your stress, all these things. There's a lot of things a person can do to have a great chance to minimize or even get rid of their symptoms altogether. Okay, it's that combination of health habits and the imaging finding that determines the symptoms. It's not just the imaging findings alone, not at all. Okay. All right, so let's see here. What are some common spine abbreviations? DDD is degenerative disc disease. DJD is like the most common abbreviation in all of medicine, degenerative joint disease. CS, central stenosis. FS, foraminal stenosis. Okay, what besides ischemia can cause degenerative disease? You know what, I'll save that for next one. So that'll be it for today. I hope you found that helpful.